The examination of the neck always begins by inspection to identify an asymmetry or mass. Learn the location of the following landmarks. All of them are easily palpable: hyoid bone, thyroid cartilage, cricoid cartilage, and superior tracheal rings. An enlarged lymph node or a neck mass may be more precisely described by noting its location within the anterior or posterior triangle of the neck. Anterior triangle boundary, middle of the neck, anterior border of sternocleidomastoid with the base being the inferior border of mandible, posterior triangle boundary, anterior border of trapezius muscle, posterior border of sternocleidomastoid muscle, with base being the middle 1/3 of clavicle, and supraclavicular fossa. Note the location and technique of palpating the following lymph nodes: occipital, postauricular, preauricular, submandibular, submental, posterior cervical in the posterior triangle, deep cervical covered by the sternocleidomastoid muscle, supraclavicular, and infraclavicular. When a node is palpable, note location, size in centimeters, mobility, fixed or mobile, consistency, soft, firm, hard, and presence or absence of tenderness. Inspect the neck for any visible enlargement of the thyroid gland. Extending the neck increases the visibility of the thyroid gland. The gland may be palpated using an anterior or posterior approach. For the anterior technique, turn the head to the ipsilateral side to relax the sternocleidomastoid muscle. Displace this muscle with the third finger and position the index finger and thumb adjacent to the left lobe. Place the index finger adjacent to the midpoint of the thyroid cartilage and the thumb adjacent to the tracheal rings. Place the opposite thumb adjacent to the trachea and displace the trachea towards the examining index finger and thumb. Ask the patient to swallow. The lobe of the thyroid gland will move between the thumb and the index fingers as the patient swallows. For the posterior technique, place the fingertips of each hand adjacent to the thyroid gland, parallel to the trachea, cricoid, and thyroid cartilages. When the patient swallows, the gland moves along your fingers and its size may be estimated. Always estimate the size of the thyroid gland. Normally, the gland is 25 to 30 grams and may not be easily palpable. When the gland is diffusely enlarged because of hyperthyroidism, a systolic vascular sound called a bruit may be audible. Note the contour and amplitude of the carotid pulse. It is best to visualize the carotid pulsation. Palpation, especially in the elderly, may reduce the cardiac rate because of pressure applied to the carotid sinus, or may decrease blood flow if the carotid artery is partially or completely occluded. If palpation is necessary because the carotid pulsation is not visible, it should be performed gently in the inferior neck, inferior to the bifurcation of the common carotid artery, which is at the superior level of the thyroid cartilage. A bruit is a sound caused by turbulent flow in a partially obstructed artery and may be a clue to the presence of atherosclerosis in a vessel. Auscultate for bruits by listening at the level of the bifurcation of the common carotid artery, a common location of atherosclerosis. The sound may vary in pitch. The bell is easier to use in this location because it may be awkward to create a tight seal with the diaphragm. Usually the diaphragm is used for high-pitched sounds and the bell for low-pitched ones. A venous hum may be audible in children and young adults. It is a continuous low-pitched sound, louder in diastole, that originates from the blood flow in the veins of the neck. The sound of a venous hum may be obliterated by occluding the jugular vein in the supraclavicular fossa using gentle pressure. The veins of the neck provide information about the heart and can be used to indirectly measure the central venous pressure. Venous waves are transmitted to the surface from the internal jugular vein or are directly visible from the external jugular vein. Venous waves are the result of impedance to flow and the release of the impedance, causing distension of the walls of veins and their return to normal diameter. These undulations are properly called waves and not pulses because there is no propulsive force present. Use a tangential light to highlight the waves. We will return to a description of the venous waves when auscultation of the heart is presented. Central venous pressure can be measured indirectly by measuring the height of the venous column in the neck. An elevated venous pressure is being simulated by occluding the right external jugular vein. The sternal angle is the reference point. It is 5 centimeters above the right atrium. With the patient at 30 degrees, turn the head to increase exposure and use a tangential light to identify the height of the venous column in the internal jugular vein. If the internal jugular venous column cannot be identified, use the external jugular vein. Measure the height of the column above the sternal angle by using a centimeter ruler and another object providing a straight line, for example, a tongue depressor. The central venous pressure is normally less than 10 centimeters of water. Therefore, allowing for the sternal angle being 5 centimeters above the right atrium, the height of the column above the sternal angle should be less than 5 centimeters.